Again, thank you. Gosh, what a pleasure to be here. And welcome to this is our home, Nashville, Tennessee. And David and I, represent Vanderbilt Medical Center, and specifically the Voice Center at Vanderbilt. And the Voice Center history goes way back, but we are in Music City, USA. So that was kind of the impetus from my mentor, Dr. Bob Ossoff, to start a center really completely dedicated to voice care. Since that time, the Voice Center's kind of morphed into, we do other things. I mean, we take care of speech, voice, swallow, airway problems. But obviously today our focus is on the patients that we see with movement disorders of the voice. And David and I, we are literally a team, and unfortunately our team is being broken apart through no fault of mine. Actually, it is kind of the fault of mine because David was one of our fellows. So for those of you who are familiar or not familiar with medical training, so for us to get to where we are, we go through our 4 years of college, 4 years of medical school, 5 years of residency, and then if we want to become a super specialized otolaryngologist, try to say that 5 times, if we want to be super specialized, then we actually go do a fellowship. And that fellowship can be focusing on ear disease, it can be focused on facial plastic surgery, pediatric ENT, but we have a fellowship in voice or laryngology. And so David was our fellow, 7 years ago now? Hard to believe. So David is kind of a homegrown success story. He did his residency in Seattle, but we were fortunate to keep him here after his fellowship, and he's done some fantastic work, including the work that he's done with the Academy. And so my part of this presentation is really going to be a practical part. His part is the really smart part, and he's the one that's done a lot of the research that hopefully is going to help us to help you as time moves forward. So, but anyway, he is going to be leaving us to go take over the research, the voice research at the University of Wisconsin in Madison. So, as a mentor, I'm extremely proud of what he's doing. As a person who spends a lot of time doing Botox injections, I am extremely sad that he is leaving because he really does share the very busy practice that we have at Vanderbilt. But for those of you who do live in Nashville, and I do see a lot of familiar faces out there, we are recruiting someone who's going to be hopefully as good, although that'll be a big challenge, as Dr. Francis. So also those of you who come to us on a semi-regular basis, I just want everybody to know I do wear something other than scrubs. All right. So with that, we have to say that we're in medicine. So every presentation we give, we have to tell you that we don't make any money from anything that we're talking about today. We really don't make a lot of money doing much other, less money, put it this way. This is our home. This is the Vanderbilt Bill Wilkerson Center on the Vanderbilt Medical Center campus. We've been very blessed to have, it was originally going to be a whole building that was dedicated to our department through an endowment, but Vanderbilt has grown so much, and if those of you, if you've been to downtown Nashville, there are cranes everywhere. And we are constantly building. So we do share that building, but you can't read it on that slide because it's too small. But it does say on there the Bill Wilkerson Center for Otolaryngology, I think, and Communication Sciences. So you'll notice too on that first slide, I did say movement disorders of the voice. I did not say spasmodic dysphonia, and certainly don't take that as kind of an affront to the NSDA, because it's really not meant to be that. We take the word movement disorders from our neurology colleagues. One of their subspecialties is movement disorders. And things like dystonias do fall under the movement disorder category. And, in medicine, we like to put things in a nice, clean box. Unfortunately, there are very few things that are perfectly fit into a nice, clean box. And the neurologic voice disorders that we manage are just like that. They do not fit in a nice, clean box. And David, you want to go through this slide?
Is this working?
Yeah.
Okay. So this is it's an interesting kind of evolution that we've seen with these conditions. For a long time, people called it spastic dysphonia. Some people thought everyone who had it was crazy. So we've come a long way in this disorder.
It still could be true,
yeah. So same for us, though. But the interesting thing about this disorder is it's no longer monolithic. It's not a one thing. So we talk about NSDA being about spasmodic dysphonia, but really what it's about is dystonias of the voice. And I think that's really important because as the population is aging, spasmodic dysphonia remains pretty consistent in terms of its prevalence, but we're seeing more of is laryngeal tremors and dystonic tremors. So there's basically, we have spasmodic dysphonia, which has two types, and you guys probably are familiar with this. Adductor type, the kind that's the most common, but there's also abductor, and then there's something called dystonic tremor. Those are the patients who have both a tremor and spasmodic dysphonia. And then there's the laryngeal tremor patients who can have multiple different kinds of tremors which have variable response to Botox and other treatments. So we're trying to make it more clear and more selective about how to treat patients, but we have to define the patients better so we know how to treat you guys the best way we possibly can. And at the bottom, there's just more and more data coming out about where these problems are coming from in the brain, and the spasmodic dysphonia is primarily from this basal ganglia cortex, and then you see the tremor coming from the cerebellum more. And we'll talk more about that, but that's just kind of an overview of how we're trying to better define the problem so that we can treat it better.
So I think just as a quick definition, I hate that these two words are very close to each other. Okay, so I just wanted to go ahead and get it out there. We use the term dysphonia all the time in our practice. And basically, dysphonia means basically abnormal voice. It can be any problem with the voice. Dystonia it's a neurologic disorder. And that's where you get the repetitive involuntary muscle contractions. It's usually action specific. You've probably heard the term focal dystonia, which spasmodic dysphonia is a type of focal, which is also close to vocal, which is even worse. Focal dystonia. Okay, so now that I've confused everybody more, and one of the reasons, and just as an example, why that was kind of humorous is so several years ago, I had the pleasure of, and this is public knowledge, so I'm not violating any HIPAA things, but because it was actually a video that Shania Twain did. But Shania Twain came to us, and through her evaluation, we determined that she had muscle tension dysphonia. And unfortunately, well, not unfortunately, but I did have some folks come in and say, "Oh, I hear Shania Twain has SD." And I was like, no, I mean, I had to be very careful with what I was saying, but again, that term dysphonia has different meanings. So she did not have spasmodic dysphonia. She had muscle tension dysphonia. So again, there's just kind of the semantics of these words, I think, is very important as you guys hear, on social media and anything else that's out there regarding voice problems. So I don't even know if all of y'all have actually seen a normal laryngeal exam. You've all probably seen your own exam. So I thought I would just quickly show, these are my vocal cords. Now, one thing I always tell my singer patients is I'm very proud of my vocal cords. And you'll hear me say vocal folds too. We kind of sound kind of intelligent when we say folds. But what that I do tell my singers is clearly it takes much more than beautiful vocal folds to be a really nice singer, because I am not. But again, that's normal, okay? And so again, in medicine, we tend to focus on the exam a lot. So as we talk about, I mentioned muscle tension dysphonia, laryngeal dystonia, which is a term that actually Andy Blitzer, I think, has started to use more often instead of spasmodic dysphonia to describe what we're seeing with you guys. And again, I just wanted to kind of show you the difference between the two. And these are, I picked out the most in-the-box examples I could. And as you're going to find or have already found, there is so much overlap with what we hear and what we see that it's sometimes very hard to find the right answer. And I know y'all have probably experienced that.
Okay. The rainbow is a division of white light into many beautiful colors. These take the shape of a long, round arch with its path high above and its two ends apparently beyond the horizon.
Now, on this one, this is an exam done through this person's nose, so this is a transvagal exam. A lot of squeezing going on that you can see above the vocal folds. So this person was treated with voice therapy. And here's her voice.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
So again, her voice is now smooth. There's much less constriction going on her exam. She does have a little prominent blood vessel on that one side. But anyway, my point there is that if you're not tuned in to look at the big picture, some people could just as easily have diagnosed her with a laryngeal dystonia or spasmodic dysphonia. And she got better with voice therapy, which that almost by definition tells us it's not a neurologic voice disorder.
One of the things that's interesting about that is when we look at how long it takes patients to actually get diagnosed, it's a long time. What we've seen is about 4 to 10 years people have their condition before they actually get a diagnosis, which is crazy considering how big a deal this is for all of you. And so, even otolaryngologists and physicians aren't aware of what this is because it's rare enough. So it's important that you continue to educate people about it because that, we don't do a very good job of identifying this condition. And that's another point that can be made because a lot of times patients get referred to us for spasmodic dysphonia. It turns out they have MTD. And so that's a big difference.
And so I wanted to kind of talk a little bit about our experience at Vanderbilt. And I wish I could say that I was part of the 1990, it may have been in 89, but we have had a spasmodic dysphonia Botox clinic since at least the late 80s or early 1990s. And that was started by Jim Netterville, who's still one of my colleagues at Vanderbilt, or our colleagues at Vanderbilt. And then Mark Corey, who is now at Mount Sinai up in New York, but some of you may have even met him. He was at UCSF as well before that. But it's hard to tell. Anybody who's been in our little treatment room at Vanderbilt, they'll see this map in there. And we sometimes forget that map's in there. And every now and then someone says, what is that map representing? And it's hard to tell. Unfortunately, the contrast isn't great. But there are a bunch of little, let's see, pointer. There are a bunch of little, so we're here, and there's a cluster of little push pins down here, but there are literally push pins that kind of go around here. It gets less dense as you move away from Nashville. And since this map was done, there have been a lot of other voice centers that have opened that also now have pretty busy practices. So this has probably been diluted a little bit, but still we have a very concentrated practice. And when we get somebody who comes to see us and they actually live down the street, we're like, yay! And I also assume, because I'll ask people, so how long did it take you to get here today? 4 hours, 6 hours, 3 hours, traffic was terrible. And then I'll get somebody that said, well, it took me 20 minutes. And I was like, oh, forgot, we do have people here locally. So, but again, I think that just wanted to just kind of go over our practice. So I quickly also want to show you these are classic examples of some MD patients. And get this out of the way. So this first one.
A long round edge with its path high above and its two ends apparently beyond the horizon.
One of the reasons why I kept the forehead involved is because that's one of the things that we look for. So not only are we listening to the voice and we're listening to the pattern of where the tightness or breaks are, but we're also looking for other potential dystonic movements. And it's amazing how many people with SD will have what we call a forehead grimace or a facial grimace when at the same time that they have their breaks. And I don't think it's completely understood as to why that happens. You know, is it a trick that the person is trying to do, or is it just the brain is sending the same signal to those two different muscle groups? But that, if I see that grimace, people with MTD typically don't have that. There's some other tricks too. I mean, you've all heard the whisper's normal with SD, and it's not with MTD. Singing is oftentimes easier with SD when it's not with MTD, which is why Shania Twain came and saw us. But I wanted to show you, this is a EMG of one of our patients with ADSD. When we do, EMG guided Botox injections, but everybody has a little bit of activity when they're not phonating, and then there's this burst of increased activity when we ask the person to actually say E or E, something like that. Here's a chronic constriction variant. So again, this one does not fit in the nice box about having tightness on just
The rainbow is a division of white light into many colorful, beautiful colors. These take the shape of a long, round arch with its path high above and its two ends apparently beyond the horizon.
So you can hear that tension throughout everything that he's saying. And so again, if you tried to, if you were so strict on, he didn't break on ear, he had ear. And again, that might be confusing as far as the diagnosis goes. So here is an abductor.
The rainbow is a division of highlight into many beautiful colors. This egg, the shape of a long round arc with its high above and its two ends apparently beyond the horizon.
So anybody who has ABSD hates the phrase, Harry hit the hammer hard. I'll say, okay, say this after me, Harry hit the hammer hard, and they look at me like I'm going to die. Dad are coming at me. And it's, again, it's almost to me sometimes more stressful. And sometimes it's even hard to figure out the difference between ABSD, because people with really bad ADSD will break on, like for path, they may break on, it may sound like path, but they know that A is coming after the P, and so they're going to let that P go so that the A doesn't catch their voice. So, and here's a typical EMG for an abductor. So as opposed to the adductor people who we have to say E, we're going for the posterior trichoarytenoid muscle on this one, and we're having them sniff because it's the opening vocal cord muscle. And so when they sniff, that's when you see the little activation there. So it tells us we're in the right spot. Now here's an interesting sample. So this person, just listen to this. Whoops, sorry. I hope you don't listen to this.
Colors. These take the shape of a long round arch with its half high above and its two ends apparently beyond the horizon.
Okay, now that's an
Go
example.
get a bigger egg. We mow our lawn all year. 81, 82, 83.
Okay, now that's an example of where you listen to that and I'm like, classic ABSD. She's breaking on all the voiceless sounds, the P's, the H's, the T's, the S's. And we did PCA injections, or the opening muscle injections, I think at least twice. Very little response. So then we started thinking, well, every now and then I hear that little catch on a voice sound. So we started doing the vocal cord injections, or the TA or thyroretinoid muscle injections. Doing those ever since. Gives her a smooth voice. So that's, again, an outside the box kind of thing. And you want to let's talk about tremor.
Sure. So tremor is an interesting thing. Like I was saying, we are seeing more and more of this, and we all can think of. I mean, some of us actually can think of relatives who had kind of a tremulous voice growing up and didn't think anything of. Some people think it's the old voice or something like that, which is a terrible thing to say. But what we've been noticing is that tremor is becoming more prominent because the population is aging. So what's interesting, though, is tremor doesn't come in one flavor. It can come where the whole larynx will go up and down, or it can go side to side, front to back, or some combination. And what we've noticed is, in general, we talk about treating this condition, and the literature and what people have said in general is Botox doesn't really work very well for tremor. But that may not be right. What we've noticed mostly with this group is that the direction of the tremor seems to matter. So why does that, who cares? Well, what matters about that is that if we inject the same muscles that cause the tremor are the same muscles we treat when we treat Spasmodic Dysphonia, they should get better. Their tremor should get reduced. So we have started to kind of sub-classify patients based on the directionality of the tremor in their throat. So you can see here that the tremor is mostly kind of on the sides. See that, how it's kind of closing like that? That's very characteristic. We refer to as a lateral tremor. And why that matters is because if we inject those same kind of closing muscles, that TA muscle that we described for Spasmodic Dysphonia, for adductor Spasmodic Dysphonia, we can actually get these patients to have a pretty normal voice again, which is great. And so this is a situation where we're trying to hone in on better treatment for a group of patients who, some people just didn't think there's anything we could do for them. And then you can see here, this is kind of the EMG tracing for what we call lateral vocal fold tremor. And you can see that there's, when they say E, you can see the rhythmicity of the whole thing where it happens every 3 to 4 times per, or 3 to 10 times per second. So this is kind of an example of what a tremor would be. Again, we talk about Spasmodic Dysphonia, but the group that's affected by these neurologic conditions is much bigger than just Spasmodic Dysphonia, and they should be, I know Charlie feels strongly that they also should be included.
And the lines are kind of blurred, quite honestly. And I think if you look back at the patients that we first started treating back in the 90s, and I've been doing it now since 97 actually, that I think some of the people who had a really hard type tremor were diagnosed with SD back then. And that's okay. I mean, because really it's a little bit of semantics. And most likely the same neurologic processes are going on where it's improper signaling from the brain. And we have patients that have classic SD but will have a hand tremor or a head tremor. So it all is in that family of laryngeal movement disorders or laryngeal dystonia. And but it's very important for us, as Dr. Francis was saying, because of this example.
Yes. So this is an example of a tremor that probably may not do as well. But when you listen,
well,
so what we're going to show you is an example of someone who sounds the same as that lateral tremor patient, but will not respond as well to Botox. And that's, again, because of where
It's a division of white light into many
so you can hear that there's
colors.
kind of a rhythmicity. So it's not
These
just
take
sounds
the
that are bothering these
shape of
patients,
the
it's just all
large with
up and
its
down.
heart.
And so this patient has a tremor that you can see comes from all over the pharynx, the throat, the singing. See how the whole throat is going. So that's a little different because that patient we wouldn't expect to do as well. And that's why it's actually important to look, because if someone has a tremor, we may or may not have as good results in that person. So just another example of how there's lots of flavors.
Okay. And so, this, I don't think this slide shows you anything new, but we talk about treatment, kind of put them into these categories. And, voice therapy certainly can help, and I think Melissa Kirby's going to talk about that a little bit. Medications, not so much, unless I put medication / alcohol next to it. Medications for the movement disorders just typically don't help the voice as much. And again, we don't know why that is. It's because these are just small muscles and you're just not getting a major effect. A lot of our patients are on these medicines though because they do have other muscle groups that are involved. Obviously Botox, which is our mainstay, and then surgery, and I'm going to walk out when Dr. Burt gets up and talks. So, sorry, don't care what he has to say. Okay, so when we talk about a little bit, so Botox, okay, so, this is kind of my day when I'm in Botox clinic, okay? And I could have put probably 20 other dosing combinations up there for how we use Botox in our practice. Everybody's different. This is not like, you come to the doctor, you have strep throat, and you're going to take, 500 milligrams of amoxicillin 3 times a day. Everybody does. Everybody in this room would get that same prescription. Well, Botox doesn't work that way. And, there are nuances to that. And I think, one of the reasons we're successful is because we have a high volume practice. And with that high volume practice, you start learning that, you people aren't alike. So we have to work with you, and sometimes we don't get it right the first time, and sometimes, it takes 2 or 3. Sometimes you do well for a period of time, and then something changes, and we have to kind of think outside the box yet again.
Yeah, this is one of those examples in medicine where one size does not fit all. And it's very important that we recognize that. And people want to be able to weigh you and look at your height and figure out the dose. That doesn't work. I have, 7-foot tall men who need this teensy little dose, and we have little ladies who need a huge dose. And no one's been able to really explain that very well. So the bottom line when it comes to dosing, it's as much about a conversation as it is about the science. The Botox works, but you have to have that conversation. It's not the doctor telling you. It should always be a conversation, and that's how at least I do it. Sure. So I wanted to show you some boring slides now. These are all numbers, but basically this is kind of hot off the press in terms of looking at our experience. So what we wanted to do was kind of look at who are you, and who are the people who have these different conditions. Because if we can understand better who has these conditions, we may be able to get some insight into what causes them, how do we treat them better, etc. So what we did was we broke down things into ADSD at the top, dystonic tremor, laryngeal tremor. And I apologize for how small this is, there's a lot of data here. But I'm going to focus on a few things. So the age at presentation for these different conditions. So like I said before, ADSD is what classically we heard there. The dystonic tremor is if you have ADSD plus a tremor or just a tremor by itself. And what's interesting here is that patients with ADSD are much younger than when they present with tremor. They're also much more commonly women. Laryngeal tremor is not something, either men don't come, it's possible, or this condition affects women mostly. And what's interesting about this, people always say, oh, that's essential tremor of the voice. The percent of women and men who have essential tremor of the limb, like the hand tremor that's classic, it's 50-50. So here it's 90% women. That's a big difference. So that argues against the argument this is an essential tremor. The other things that I think are interesting is family history of vocal tremors. Okay, so maybe not surprisingly, ADSD patients did not really 0.3% had a family history of tremor somewhere in the family. But again, laryngeal tremor had a high, 1 in 10. And then the other thing that's interesting is that patients who presented to us, there's a fair number of you who have another movement disorder. So it's like 1 in 10 in ADSD, and it's over 50% in that tremor group, have a hand tremor or something else going on. And then a question that always is asked at presentation, and I think it's an important question, is everyone says, does this mean I'm going to get another disease? Is it going to spread? Am I going to have Parkinson's? Am I going to get something bad like that? The bottom line is we looked at all of our patients and followed them out as long as we have, and we have 90 to 2015 or 17, I guess now. And we found that in ADSD, only 0.8% of patients develop something else. And that's probably close to the population level of getting a movement disorder. So in summary of that, so older age with tremor, women are way more common and more likely to have family history of other movement disorder presentation. And you've all lived this. This is the life cycle of a treatment. So we sound terrible at the beginning, that's phase 1, we get our shot. And then 2 is kind of the good voice period, and then phase 3 it's getting worse again. And the reason I put this up is that we keep diaries for our patients, so patients, and a lot of you know this, you kind of keep track of how you do. And this is that feedback. So this is a very patient-centered approach to treating someone. The doctor's not going to tell you what's right and wrong, because the doctor never sees you when you're in good voice. People always want to make it scientific, and it is, but the bottom line is you're happy, we're happy. And so I think that's very important. So when we talk about treatment outcomes, you guys decide if it's good. And I tell my patients, complaining is what I want, because you want to optimize it as much as you can. So this is basically when we do this big study looking at things. Oh yeah.
Okay.
So movement disorder, so we have about 817 patients that we treat here at our center, which is a pretty high number, and we're just talking here about, which is just basically a diagram of who we included in our study. And this is an outcome study to see how patients do with these 3 conditions. And so again, the older, your laryngeal tremor, you're older, and this, we can just move on past this one thing. So we did this fancy modeling to see how patients did, and this is based on your diaries. So the numbers are days, number of good voice days. I'm not telling you what a good voice day is. You're telling me what a good voice day is. So I asked you guys how it went. So what we found was that people who have ADSD do better than patients who have a combination or have the tremor, okay? By what, 10 days? In all of our models, about 10 days. And so if you were talking to a scientist, they'd say that's a significant difference. The bottom line, though, is all of those are good. That's a very good thing. And so if you know how long you're going to last, then you can adjust your schedule so that you're in good voice all the time. So this is not, so there's statistically significant, clinically significant. And this is something where I would argue it's not that different. The other thing is we ask patients about, did you get to where you wanted to be? Well, optimum voice. Again, I don't decide what optimum voice is. You decide. So again, about 90% of patients who have ADSD during an injection were really happy and got back to normal for them, or as good as they've gotten. And again, you can see as we go to the right, it's not as good, but again, 70% of injections were people were really happy and were back to where they wanted to be. So this is just to say that, we may not always get it right, but we should be able to get it right most of the time, and that should be your expectation. And you really just need to know that people are looking at this and trying to hone in on how do we treat you folks better. And that's really what I want to make sure is clear. So we're learning a lot about this. We're trying to make sure that we can find out what are those things about you that we need to think about when we're doing injections. But the bottom line at the end of the day is this is a conversation. We don't know all the answers yet, but we're going to get there. And the last thing I would say about this process, about studying a disease or a condition like this, is that there's not, if you were comparing this to heart disease, there's not a lot of you. But you all are so affected in a day-to-day way. Heart disease, you may not feel every day. you have high blood pressure, you don't feel it. But in this, you live this. You are saying something, you talk with your friends, it's part of your personality. So you have a lot more in this than if someone had high blood pressure. So I would just urge you, when there's research to be done, to participate, to think about it, because if you all got together and you all helped with big research projects, you could make this problem go away a lot faster.